Okay, we'll get going. So, good afternoon, everybody, and welcome to our second Feminist Thinking Seminar of Michaelmas. And it's wonderful to see faces familiar and new in the room today. My name's Illyri Watson, and I'm the Fellow in Queer Studies here in the Humanities Division and a lecturer and mentor for the Women's Gender and Sexuality Studies programme. I'm going to move your glasses under here, if that's okay. I've knocked them and they're going to fall. So before I introduce today's brilliant speaker, I'm going to just tell you a little bit more about the Feminist Thinking Seminars. So for those of you who are unfamiliar, seminars are led by students in the Women's Gender and Sexuality Studies Master's Programme. I'd like to thank Beth and Tallulah in particular for their wonderful work in coordinating today's event. These seminars aim to open up lively conversation across feminist, queer, trans, critical race, post-colonial and disability studies. Bringing together scholars, artists and activists from around the world, the series invites critical and creative dialogues on identity, difference and power. These are grounded in openness, humility and critical reflection that brings academia and activism into dialogue towards collective action. And the topic of today's seminar embodies that call for openness, humility and critical reflection. And we're delighted to welcome Labour historian Dr. Geraldine Fela, Postdoctoral Research Fellow in the School of Humanities at Macquarie University in Sydney. Her research and teaching traverse the histories of gender and sexuality, labour, social movements and medicine. Her first book, Critical Care, Nurses on the Frontline of Australia's AIDS Crisis, examines the role nurses and nurses' unions played as carers, activists, educators and advocates for those living with HIV AIDS during the crisis in Australia. Please come in and grab a seat if you're free. Today's talk, Blood Politics, Nurses in Australia's AIDS Crisis, draws upon the insights of critical care. Reading Critical Care, I was really struck about how Geraldine tells this history through an idiom of clarity, compassion, and queer feminist activist attentiveness. Her writing joins archival precision with the intimacy of oral history. She centres the voices of nurses, voices that are sometimes tersely factual, sometimes darkly humorous, sometimes mournful or nostalgic for a lost way of living, being together and nursing. These are individuals whose emotional and political labour has all too often been made invisible. Geraldine foregrounds empathy without sentimentality in a style that listens carefully, bears witness to trauma and foregrounds solidarity and resistance. Critical Care stands as a model of activist historiography, rigorous and generous, written with an ethical care that honours those who, in her words, chose compassion, care and solidarity over fear, while prompting us to reconsider what care, collectivity and political responsibility might mean in times of crisis today. And testament to the absolute brilliance of Geraldine's work, Critical Care was awarded the Prime Minister's Literary Award, so Australia's most prestigious national literary prize, earlier this month. And those of you affiliated with Oxford can access Geraldine's book via Solo, and I implore you to read it. So, without further ado, please join me in welcoming Geraldine.
Thank you, Illyri, and thanks everyone for having me. That was a really, really generous and lovely introduction, so thank you. And it's always lovely hearing someone else talk about your work because you're kind of like, oh, did I do that? So I'm glad to hear I hopefully did do all those things. Thank you. Before I begin, in Australia, it's customary that we acknowledge the custodians of the land that we live and work on. I'm an employee at Macquarie University, which is on the land of the Darug people, but I live and work on the land of the Wurundjeri people of the Kulin Nations, and that's where this book was written. So, as Illyri said, my name's Geraldine Fela. I'm a Postdoctoral Research Fellow at Macquarie University, and I'm going to talk to you today about my book, Critical Care, Nurses on the Frontline of the AIDS Crisis, which is the first historical account of the important role that nurses and their unions played in responding to HIV and AIDS in Australia. And this is a book that started as a PhD, well, it started as an honours first and then a PhD and then turned into a book. So between 2018 and 2019, I travelled across Australia to each state and territory, from capital cities to country towns, recording the stories of nurses who cared for people with HIV and AIDS between 1983, which was Australia's first recorded AIDS-related death, to 1996, the introduction of effective treatment. And I spoke to nurses who worked in a diverse range of geographic and clinical settings: urban, rural and regional areas, wards, clinics, homes and community nursing. And as I travelled around collecting these oral history interviews, I also conducted documentary research in the archives of various nursing unions, in Australia's Queer Archive and in the National Archive, which holds federal government documents. So why nurses? Why does this history matter? And there's...
Sorry, thank you.
It's okay. There's a kind of simple answer to this and a slightly more complicated one. And the simple answer is that nurses played an absolutely crucial role in responding to HIV and AIDS in Australia and indeed around the world. In the absence of effective treatment, the care nurses provided was particularly important. Nurses gave physical and emotional comfort when medicine could offer only limited treatment. They negotiated homophobia and complex family dynamics, and they defended the rights of their patients. Despite this, their voices, their experiences, and their contribution to this significant health crisis and period of social history has, for the most part, been overlooked up till now. This is true in Australia, and it's also true in much of the English-speaking world. It's only in the last few years that academic and community historians interested in this period have begun recording the stories and contributions of nurses. Some of you in the room might know of the project The AIDS Era, an oral history of UK health workers, which received a huge grant about, I think in 2017 from the Heritage Lottery Fund. And it's an extraordinary oral history museum collection, that's being archived at the British Library and will hopefully, I hear, little birdie told me, soon be a book. So I would really recommend keeping an eye out for that. So there's kind of a few of these kinds of histories happening right now around the world, or at least in some parts of the world. So, this was a big part of my initial motivation for doing this work, was to kind of correct the historical record, to bring nurses into the social history of HIV and AIDS in Australia. And I had a strong sense of the importance of doing this now. A new generation of HIV treatment has transformed HIV care, and at least in wealthy countries, of course not in many parts of the world, but in wealthy countries, the crisis years are slipping further and further behind us. And concurrently, many nurses are reaching the end of their working lives. So now is a really crucial time to capture and record their stories. So in some ways, this project started from a kind of simple question of justice and the very basic premise of placing on the record the stories of a group who had been significantly overlooked. And as is often the case when this happens, this is a group mostly made up of working class women. But as I embarked on the research, it became clear that there was another equally compelling reason to examine the history of HIV and AIDS nurses, and that is that nurses are in fact central to the social and political history of AIDS in Australia. So I think it will be helpful here just to give you a bit of an overview of the broader history and historiography of AIDS in Australia. So as I said before, in Australia we take the AIDS crisis to be the years between 83, the first AIDS-related death in Melbourne, and 96, and the introduction of highly active antiretroviral therapy. Of course, as we all in the room know, in many parts of the world, the AIDS crisis is far from over today, and it continues to spread and devastate communities. But thanks to the wealth of Australia and our healthcare system, the acute crisis ended in 96-97, which is the same year. But the 80s and 90s were truly devastating. Between 6,000 and 7,000 people died of AIDS-related illnesses in Australia. Around 80% of these people were men who had sex with other men, or gay and bisexual men. And that statistic is important not only because it puts a number to the grief and the catastrophe that Australia's gay community experienced, but it also tells a story about the nation's public health response. In Australia, the virus was quickly and effectively contained to the gay community, Unlike in comparable countries like the US or the UK, it never spread into communities of IV drug users or among other oppressed groups, communities of colour, notably in the US. Heterosexual transmission never became a serious feature of the Australian epidemic. And this is attributed to something called the Australian model. And it has that name because Australia's particular policy response to HIV was and is internationally recognised as having been groundbreaking. The story of the Australian model goes something like this, and I use the word story on purpose. So it goes, when HIV arrived in Australia, we were lucky. We had a new reforming social democratic Labor government, a health minister whose bisexuality was an open secret, a well-organised gay community used to political activism, and some open-minded doctors and immunologists. An unwieldy partnership was formed between gay community groups, the medical profession, and state and federal governments, who all sat down together and agreed to an approach to the virus that saw public money pumped into a community-led response to HIV. Punitive and coercive models of public health based on test, contain and quarantine models were eschewed for this far more progressive and collaborative approach, which was shown to be highly effective. And you can see some examples here of safe sex material that was publicly funded in the 80s. It's kind of pretty unimaginable in many other parts of the world, or in any other parts of the world really at the time. And this quote is from community activist Adam Carr, which articulates this decision on behalf of the gay community towards partnership and collaboration with the state and the federal state and the medical establishment. So he talks about essentially doing a gentleman's agreement. We'll contain the virus, give us the resources, we'll contain it, but leave us alone to do that. And this story of coalition between unlikely allies has become the organising narrative of the social and political history of AIDS in Australia. And in a general sense, it's correct. It's right. Australia did have a more humane and progressive approach to controlling the virus compared to, say, Reagan, who couldn't even say AIDS until 1985, I think. And, of course, you had your own experience with Thatcher here. And as I said, you can see these fairly radical examples of publicly funded sex education or safe sex education. But what hasn't been attended to before now is the central role that nurses played in this story. And what's interesting is that a focus on nurses or nursing stories reveals some cracks or complications in this grand narrative partnership. And what's particularly important is that what becomes clear, and this is what I'll talk about today, is that throughout the 80s and 90s, public health and infection control models were in fact hotly contested in Australia. And it was nurses more often than doctors, surgeons, and the professional bodies that represented them who insisted on the kind of community-centred approach to public health and infection control that has become synonymous with the Australian model. So today I'm going to talk about the crucial role that nurses played in caring for those living with and dying from HIV and AIDS, and place this alongside and in dialogue with their role as political agents who help shape Australia's response to the virus. So, sorry, some water. So nurses cared for people with HIV and AIDS in a variety of clinical settings, on wards, in outpatient clinics, in their homes. And people live with and died of HIV and AIDS all over Australia, but the majority were around the neighbourhoods of inner city Sydney and Melbourne on Australia's most populated east coast. Many young men spent their last days in the big inner city AIDS wards at Fairfield in Melbourne, which is where I live, not at Fairfield, but in Melbourne, and at St Vincent's in Sydney, which is in Sydney's eastern suburbs, in the eastern suburbs. The nurses who ran these wards and clinics came from very diverse walks of life. Some were gay men and women who were drawn to caring for their community. Some had HIV themselves. Some were not themselves gay but had gay friends and family. Many were heterosexual women and some men who found themselves, often to their surprise, thrown into caring for a community that they had little connection to or pre-existing understanding of. Regardless of their background, All of the nurses I spoke to talked about how different HIV care was to what they were used to. To start with, HIV patients were totally different to their usual patients. They were almost all men, many in their 20s, 30s and 40s, often the same ages as the nurses. Many had lived through the gay liberation movement and they were used to advocating for themselves. They wanted agency over their bodies and their treatment, and they weren't going to just accept whatever doctors had to say to them. And the disease itself was also different. It was unknown, there was no cure, and treatment options were incredibly limited. Doctors could do very little for patients beyond managing their symptoms. And in this context, not only did nursing change, but the vital role that nurses play in patient care was made even more visible. In the hospital system, it's nurses who are the constant point of contact for patients, who provide the most consistent physical and often psychosocial care. And that's because it's just the nature of how how hospitals operate. Doctors kind of come in and come out of rooms and they prescribe, whereas nurses, do that kind of intimate care. In the day-to-day of living with and dying with HIV and AIDS, it was nursing, not doctoring, that patients often needed the most. As I said, because medical treatment could offer very little. But nurses eased aches and pains, they talked to their patients about fears and grief. Nurses negotiated tense family dynamics. They made sure that chosen family, friends and partners could be with their loved ones as they died. And not only were many of the nurses the same age as their patients, as I mentioned before, particularly in inner Sydney and Melbourne, they were often from the same community. Some were nursing lovers and friends, and the boundaries between these wards and the street and club scene outside the doors could be very porous. Nurses organised for drag queens to visit the wards, rolled people in wheelchairs down from St Vincent's in Sydney and into the nightclubs, into the Mardi Gras parade. You should probably know what that is. Yeah. And I always include this image because I think it captures the life of these wards. These wards weren't just all about dying. These were young people. They didn't want to spend their last days, in sombre misery. They wanted to live, as long as they could. There was a lot of joy and a lot of pleasure in these places. For many of the nurses that I spoke to, HIV and AIDS was both transformative and profoundly meaningful. Particularly for those who are gay or lesbian, this was a time in their lives when they were deeply enmeshed and contributing to their community. Many nurses, both gay and straight, described it, perhaps somewhat counterintuitively, as the highlight of their working lives. And this wasn't because they were callous or immune to the suffering that they bore witness to, but because of the deep bonds that they formed with their patients and a sense that they were truly nursing. So Sian is a really good example of this. This is a picture of her. Sian came to Australia from the UK, in the early 80s, and she'd been trained as a Nightingale nurse at St Thomas's, which you probably all know is in London. I always have to explain that in Australia, but of course I don't have to here. She remembered that she'd been taught, you do not touch your patients. You don't sit on their beds. What was important is what your hat looked like, that your belt was straight, that you had a professional demeanour all the time. But once she started caring for people with HIV and AIDS in 86, she found that faced with young men her own age, in need of palliative care, it was just not appropriate anymore in this context to have those rules of nursing boundaries and nursing professionalism. Working as a community nurse to people dying from AIDS-related illnesses in Sydney's eastern suburbs, Sian learnt massage to ease the aches and pains of her patients and to provide the human contact that was often denied to people with HIV. She remembered there was something about that relaxing time to talk that was very physical. AIDS had such an issue with touch and with physical contact, and it was a nice way to relax people. She thought of this as both physical and emotional care, and given how little treatment was available, it was, she said, probably the only thing I could really offer, but it felt like I could do something. Sian formed close relationships with the men she cared for, and she kept a diary at the time. In our interview, she reflected on reading that diary just before we met to talk, decades later. And she talked about how it was really beautiful hearing the relationships that I had, but I clearly struggled with the boundaries of professionalism because I was the only person Sometimes, or I was the only person who was there regularly for somebody while they went through this. I talked to them about their death. I looked after them while they were sick. I sat with them when they were dying. How can you do that and not become intimately involved? I talk about them as friends, not patients in the diary. This collapsing of boundaries between patient and nurse, patient and friend that Sian describes here could be very challenging. It brought pain, grief, and could be a professional minefield, particularly for gay nurses who are nursing their community. A few of the gay men I spoke to for this talk described like going out one night, going home with someone, and then going to work the next day and that person walking into the outpatient clinic where they worked. Like this incredible, a mixing of personal and professional lives that could be really, really difficult to manage. But it also unsettled hierarchies, and this reverberated through the healthcare system. Later, when Sian moved into ward-based nursing, she reflected on how and why HIV changed the way patients, nurses, and doctors related to each other. She remembered, in healthcare, you're usually nursing older people, middle-aged and upwards. You're not nursing someone who's 23 every day. But in HIV care, the patients were young, so were the nurses, so were the doctors. It would have been absurd to have had some kind of hierarchy. We needed to teach each other too much. You didn't get told what to do by a doctor. You got asked what you thought. You were consulted as a nurse. I heard stories like Sian's over and over again in the course of this research, of how in the context of HIV, a confluence of factors transformed nursing practices and the broader healthcare system. The age of patients and the identification between nurses and patients was important. The demands that patients made to be given agency, and perhaps as well, HIV nursing attracted a certain kind of nurse, people like Sian, who were open to difference and open to norms being challenged. There was also a much bigger industrial context at play, and this shaped the confidence of nurses to break with norms of care, and it unsettled established relations of power within the medical system. The emergence of HIV in Australia coincided with a crisis in the healthcare system and a strike wave among nurses that transformed the politics of nursing unionism. In the late 70s, Australian nurses had engaged in industrial activity for the first time, from short strikes to work bans. By the early 80s, there were strikes all over the country. In New South Wales, and that's where Sydney is, a radicalising rank and file elected 2 left-wing militants into their union's leadership. Both had come to union politics through the social movements of the 70s and had connections to the women's liberation movement and to gay liberation. Perhaps most notably in Victoria, which is where Melbourne is, nurses struck for 50 days in 1986 under the militant leadership of Irene Bolger. And it was in this context that nurses increasingly rejected the very gendered hierarchy of the medical system. They were no longer willing to be doctors' handmaidens as they were kind of configured in the Nightingale model. They were instead asserting themselves as professionals and as experts in their own right. It also meant that nursing unions were quick to take up questions of discrimination and homophobia that were associated with the emerging epidemic. Because, and we all know this, I think, in the room, that HIV is a disease inscribed with fear, prejudice, and sexual moralism. It was at the time particularly, and still is in many parts of the world, famously put by Dennis Altman, the disease of poofters, junkies, and whores. That's how it was conceived of. And of course, healthcare workers were not immune from this. Many nurses that I spoke to, particularly who worked outside the big inner city AIDS wards, described distressing examples of discrimination in their workplaces. They shared stories of dying men left alone in isolation rooms, where they were the only ones willing to even enter those rooms, let alone touch or care for the patient. And this is partly driven by homophobia, or a large part driven by homophobia, but also by anxieties around transmission in clinical settings. The leadership of the different state-based nursing unions were quick to respond to these anxieties, using the union as a tool and a structure to educate nurses about the virus. So from 1985 onwards, state branches and the federal body of the union published articles for members about the basics of HIV, imparting information about transmission, for example, that it was safe to touch people with HIV, that the virus couldn't be transmitted via saliva. Very obvious things to us now, but not obvious to people at the time. And these articles also updated nurses with political points around, anti-gay violence and discrimination in the healthcare setting. In Victoria, which is the second most populated state in Australia, and where the large city of Melbourne is, the union branch organised seminars in hospitals in the capital, but also in regional and rural areas to educate nurses about HIV. Nurses around the world are held in high esteem in their communities, and it was the union's view that when armed with the facts about AIDS, nurses could play an important role in challenging the panic and prejudice associated with the virus, both in hospitals and in wider society. And this is a quote here from Bronwyn Ridgway, who is the leadership of the New South Wales Nurses Association, the union there, where she talks about how the union kind of conceived of the role that nurses could play in educating people and confronting AIDS prejudice. And this view that was taken about nurses having a kind of political role in responding to the virus would become increasingly important over the coming decade, as with growing panic over transmission, two conflicting approaches to public health and infection control emerged. The first, advocated for by many doctors, and not all doctors, but a lot of prominent doctors and the professional associations that represent doctors, was a biomedical model based on traditional test and contain approaches to infectious disease. And it took as its starting point the idea of widespread testing and the compulsory notification of serostatus, which is HIV positivity. This meant that state health departments would be notified of each positive test, allowing them to establish rates of infection, identify positive people, and record where they live. The second model, which the gay community and other affected groups preferred, and which has now become synonymous with the Australian approach to HIV, emphasised community empowerment and education. This social model of infection control eschewed the biomedical model's kind of more punitive aspects, the trace, track, and contain, and the legislative tools to punish and control so-called high-risk behaviour that came with things like national registers. It was this second social model of public health that nurses and their unions threw their weight behind. They were influenced by the emerging School of New Public Health, and also in many cases by the close personal and political ties between the leadership of the gay community and this new layer of nursing militants who'd come into leadership in the unions and were also now in the membership. And this here is from Marilyn Beaumont, who was the National Secretary of the Australian Nursing Federation, which is the national body. And she talks about the approach they adopted and the influence of what's called New Public Health on her leadership. He's just talking about the Ottawa Charter, which kind of was a World Health Organization document in 1986, but it put out this kind of social model of public health and disease control. And she talks about it being this emergence of new public health being a light bulb moment. The idea of needing to work more closely with communities, that health is created by social conditions, not by healthcare professionals in an acute health system. And she remembers as well that this approach was in constant tension with the professional associations representing doctors and surgeons who hated this demedicalisation of the virus and the challenge to their authority that this posed. So the first big stoush between these two models of public health occurred in the state of New South Wales in '84 around the question of registers that I mentioned before. So registers of people who tested positive for what was then being referred to as AIDS antibodies. And you can imagine the panic in the gay community over the idea of going on a list at a time when quarantine camps seemed to be very much on the agenda, and in fact, sex between men was illegal in most states in the country. There was significant political pushback from the gay community, which the Nurses Union enthusiastically joined. So they took to all of their councils, all their kind of members' meetings, motions opposing the introduction of an antibody register, and it became union policy. And ultimately, a watered-down version of the register was introduced that was completely anonymised and associated with no significant legal powers. So it was considered very much a victory for this more social model of public health. But this was far from the end of this political contest. These debates around models of public health occurred again and again over the coming decade. And I'm going to talk to you about one stoush, which is a funny way to put it, but it kind of does feel like that in the history. These sort of big clashes, I guess, of ideological positions, basically, around public health. This one stoush where nurses asserted their professional and their industrial power to intervene in a public health debate in a way which fundamentally reshaped approaches to infection control in all of the Australian healthcare system. So in 1989, AIDS wards, particularly in Sydney and Melbourne, were filling with more and more patients. And the Australian Medical Association and the Australian Association of Surgeons, the two peak bodies representing those professions, who were always looking for ways to introduce testing regimes, began campaigning for targeted and compulsory HIV testing of so-called high-risk groups in hospitals, which really meant singling out gay men and injecting drug users to make healthcare contingent on them submitting to testing. These same bodies were also campaigning for mandatory testing of all surgical patients. The leadership of nursing unions rejected the idea of making healthcare conditional on testing, arguing that this could stop vulnerable people seeking healthcare and could lead to serious discrimination in healthcare or clinical settings. They argued instead for universal precautions, the idea that everyone should be treated as if they had HIV or other blood-borne viruses, rather than singling out or profiling particular individuals. And this approach wasn't the norm then in Australian hospitals. And you can see here the clear articulation of this position in a media release responding to the doctors' and surgeons' calls for mandatory testing. Nursing unions pointed out that if everyone was treated as if they had HIV, then not only would this avoid targeting already marginalised groups, but healthcare workers would also be far safer. They saw universal precautions as a way of marrying OH&S, occupational health and safety, with a politics of anti-discrimination. Doctors and surgeons, or at least their organisations, dismissed universal precautions as nonsensical. For the most part, this debate took place at the level of policy, in government back rooms, in hospital boardrooms, and occasionally in the media. However, there are examples of everyday rank-and-file nurses intervening in this debate as well. The most important of these occurred in 1991, when a conference of AIDS nurses threatened to place work bans on compulsory testing, so to essentially take industrial action. So in 1991, the AIDS Nurses Resource Group, which is a working group of the Nurses Union branch in Victoria, organised the first national conference, nurses conference on HIV and AIDS. Hundreds of nurses attended the conference. They kind of shared clinical knowledge, research updates, and discussed legal, ethical, and political issues that they were encountering in their work. In a series of resolutions, the conference floor addressed directly the political and social issues raised by the virus and sent a strong and clear message to the medical establishment or medical profession. And you can see here the kind of key resolutions or the key parts of the resolution. We will not assist you in carrying out non-consensual HIV testing on people seeking care. We will not assist you in making healthcare conditional on consent to HIV testing. I think this is really the only example, at least in Australia, of workers actually taking industrial action around the question of HIV-related discrimination, and a very important one. In a large part, thanks to the advocacy of nurses and nursing unions, the HIV testing regime that doctors and surgeons wanted to introduce was never introduced in Australian hospitals, and universal precautions were adopted as the baseline infection control protocol, and they still are to this day in every clinical setting in Australia. When I asked Marilyn Beaumont, who was the National Secretary of the Nurses Union, why she thought it was nurses, not other parts of the healthcare workforce, that had stood so consistently with their patients in the context of a virus that at the time was so new and so frightening. And she described what we might call a politics of care, the ways in which the nature of nursing work, the effective and intimate relationships that between nurses and their patients spilt out of the wards and into a broader political commitment to defending their rights. She said nurses are much closer to the people, to the individual. They hear the story differently. They see the context of the person's life differently because of the time, that 24 hours, 7 day a week, when they're in acute care. There was a lot more time for conversation then too. The throughput wasn't so fast. We saw the devastation of what was happening to the number of people, the rapid progress to death. And there were a whole range of things that were so obviously discriminating, we had to do something. So hopefully this has painted a kind of broad picture for you of the contribution of nurses to Australia's AIDS response, both as caregivers and as political activists, and of the relationship or the dialogue between these two orientations. I want to shift now into a bit more of a case study and follow the story of just one nurse, Auntie Gracelyn Smallwood, who is a proud Birragubba Kalkadoon and South Sea Islander woman. Hers is a story that is, on the one hand, very particular. It's a story of Indigenous nursing and of the specificities of responding to HIV in Aboriginal and Torres Strait Islander communities. But her story also speaks to something broader, of the role, once again, that nurses played as advocates, bringing their expertise to bear on policy discussions and shaping political outcomes. In Auntie Gracelyn's story, there are also some broader political questions around the intersections between health and public health and settler colonialism, of the power of anti-colonial politics to shape health outcomes. This is, of course, perennially relevant in the settler colony of Australia, but also in many parts of the world, all around the world. So, who is Auntie Gracelyn? So, Auntie Gracelyn was born into a family of 19 children, more than a decade before Australia voted to count Aboriginal people as citizens in the Constitution. She grew up in a condemned house on the outskirts of the racially divided city of Townsville, which is in the very far north of Queensland, so right up the top of Australia. Her father was a respected community activist who'd been removed from his family and sent as a child to Palm Island, which is a notoriously brutal mission. And a mission is like a reserve. It's part of the colonial regime of control over Aboriginal people. And she explained to me in our interview how poverty, racism, but also resistance and resilience were defining features of her childhood. So she talks about how her father's experience of being removed from his family, stolen, and sent to the mission shaped her political kind of outlook on the world. She says, I couldn't understand how we lived in such low socioeconomics, how Aboriginal and Islander people weren't even allowed to get any Centrelink, any social security, because we weren't citizens until 1967. So we lived in low socioeconomics like most other First Nations people. In 1969, partly in response to this injustice that she grew up in and was struggling to understand, coming to terms with, and wanting to fight, she began her nursing training in Townsville General Hospital. She completed it 4 years later and became one of only a tiny handful of Aboriginal nurses in the country. At the same time as she was completing her training and moving into the workforce, an emerging Indigenous rights movement was taking the political stage. Influenced by figures like Malcolm X, groups like the Black Panthers in the US, and anti-colonial movements across the global south, this growing Black Power movement emphasised what Aboriginal activist Gary Foley, who was a founding member of the Australian Black Panther Party, called a new form of Koori community organisation. And Koori is a name or the way a group of Aboriginal people in New South Wales describe themselves. These organisations were first and foremost Aboriginal controlled and were based on the premise that Aboriginal people themselves had the economic, political and cultural resources to confront and solve the challenges facing their communities. Beginning in the inner city communities of Redfern and Fitzroy, which had big Aboriginal communities in Sydney and Melbourne, Aboriginal run and controlled health and legal services soon spread across the continent. And this here is a photo of the first Aboriginal controlled medical service, which was established in Redfern in Sydney. And these ideas influenced a generation of black activists, including Aunty Gracelyn, who, already highly politicised by her experiences of poverty and racism, was drawn to this emerging politics of Aboriginal control and self-determination. In 1975, she helped found the Townsville Aboriginal and Islanders Health Service and was the first registered nurse to work there. And by 1981, she was a significant figure in the field of Indigenous health, a regular speaker at conferences both nationally and internationally. In 1985, she travelled to the United States. And it was here that she realised the significance of HIV, when a friend died of the virus during her visit. She returned to Australia concerned about what this could mean for her community, where sexually transmitted disease was already a serious health issue, a result of the poor health infrastructure in many communities, as well as the corrosive effects of poverty, intergenerational trauma and oppression. And as the danger was dawning on Aunty Gracelyn of HIV, a significant debate was taking place in the highest offices of Australia's AIDS response about how to respond to the virus in Indigenous communities. In November of 1986, prominent Dr. David Pennington resigned his position on the National Advisory Committee on AIDS, NACAIDS. Pennington was convinced that the approach to HIV that was being advocated for by nurses in the gay communities, the approach I've already outlined based on community engagement, would not work in Aboriginal communities. Instead, he argued that a medical model of infection control, most significantly the compulsory testing of Aboriginal people in remote communities, was required. And here you have a quote from Pennington, where he says the standpoint of the gay community may differ from the traditional Aboriginal viewpoint. Aborigines are not concerned about superannuation or life insurance or things like that. It's not hard at all to discern the racist assumptions underpinning his argument for compulsory testing, and Pennington was not alone in this view, and in viewing and positioning Aboriginal people as incapable of managing their own health. This deficit approach to Aboriginal and Torres Strait Islander communities and their health led many healthcare professionals in the 80s and 90s to predict an epidemic of catastrophic proportions in remote communities. Prominent doctors like Fred Hollows, who some of you might know, is the eye doctor, unfortunately was one of them who theorised that these communities would mimic, and again, you know, the racism of this is not hard to discern at all, the so-called African model of disease spread, that is the widespread heterosexual transmission. Some went so far as to predict that HIV would mean the end of Aboriginal Australia. And predictions like this, that Aboriginal people are a dying race, have been a feature of settler colonialism in Australia since 1788. They have a very important purpose in settler colonial discourse. They serve to obscure and deny Aboriginal resistance and resilience in the face of colonialism and colonisation, invasion and colonisation. And these predictions were proven wrong, which I'll get to talking about. So back to Pennington, who's the doctor. So Pennington resigns from NACAIDS, from the National Committee, because he's made this big statement, he's done. Aunty Gracelyn then gets asked onto the committee in recognition of her role in Aboriginal health in the decades previously. And she wades into this very fraught political space as the new Aboriginal and Torres Strait Islander representative. Importantly, she brought with her a deep knowledge of her community and a set of politics around the importance of self-determination and community control, which she'd developed working as a nurse in Aboriginal controlled health organisations, and of course also through her own family's politics and experience of resistance. Now, Aunty Gracelyn made many interventions on this committee, but her most famous and impactful was around a particular health promotion campaign. And this health promotion campaign came about as a response to a very frightening ad that was aired on Australian television, which I'm going to try and play for you. It's called the Grim Reaper ad. It was very frightening for people at the time. It's quite funny now, but it's kind of like the equivalent of your Tombstones ad.
At first, only gays and IV drug users were being killed by AIDS. But now we know every one of us could be devastated by it. The fact is, over 50,000 men, women, and children now carry the AIDS virus. That in 3 years, nearly 2,000 of us will be dead. That if not stopped, it could kill more Australians than World War II. But AIDS can be stopped, and you can help stop it. If you have sex, have just one safe partner, or always use condoms. Always.
So, oh, sorry. Thanks, YouTube. So this ad, like, shocked. Oh, yeah, good. Oh no, sorry. This ad shocked kind of mainstream Australia, and gay community had a mixed response to it. I've heard some people say they had kind of like people would have a drinking game, like drink when the baby flies through the air kind of thing. So it had this kind of camp absurdity, and people obviously dealing with a very difficult time. But regardless, Auntie Graceland really objected to it. And particularly objected to its appropriateness for Indigenous communities. So she said, I found myself mostly with middle-class white folks who really didn't know our world. And they did a program called the Grim Reaper, and I was not happy with it. I made a comment, and strangely enough, I was listened to. I said, your world is very different to the Aboriginal world because of the poverty. I need to let you know that Aboriginal people will not identify with a skeleton and a bowling ball down an alley. And I've worked on just about every Aboriginal community in Queensland. I know if we pull the health resources together, they could do their own black media. So Auntie Graceland put together a team of health workers and social workers from Aboriginal organisations across Queensland, and which is where the state she was from. So it's the kind of northeastern part of Australia. It's a really, really big state. And they visited communities all over the state, holding workshops and meetings. The materials that they used at these meetings and workshops were then further developed in Townsville, where she was from, which is a big hub of Aboriginal community. Well, it's a hub where lots of communities come to. And the Townsville workshop was attended by community workers and elders from a wide section of Aboriginal communities across the state, as well as young people, teenagers, and they had an Aboriginal graphic artist there. And she recalled, we talked about the Grim Reaper, which was scary for the community, and one of the elders said, well, we can have our own black hero and call him Condom Man. And all of this was being sketched by the artist. And this is the figure that emerged. So Condom Man, and this is, have any of you seen it before? Yeah. So Condom Man combines an affirmative image of indigeneity with a clear safe sex message. Don't be shame, be game. And the people who produce, is it Marvel who does the Phantom? They were really pissed off because they were like, his undies are the same as the Phantom. There was some legal battle, but anyway, that got dealt with, and it became this absolutely ubiquitous public health campaign in Australia, and is really one of the lasting images of Australia's AIDS response. At the time, you could buy a Condom Man t-shirt. You would often find him on a poster stuck to the back of bathroom doors, and live action Condom Mans, like in costume, would visit Indigenous community events, handing out condoms and delivering a safe sex message. So Condom Man was entirely owned and embraced by Indigenous communities, and so was this message that he was spreading. Now, obviously, one safe sex campaign can't alone stop the spread of a virus, but the approach that Condom Man represented of building health promotion campaigns with and alongside communities at a grassroots level was then replicated by Aboriginal and Torres Strait Islander health services across the country. I visited the National Archives in Darwin, which is in the Northern Territory, and there's incredible evidence in there of communities incorporating AIDS education into ceremony and other cultural practices. And there's these kind of letters where doctors go to these, very remote communities, Yindamu, which is a small Western desert community outside Alice Springs, for example, and the doctor writes back like, I went there and they all seem to already know about AIDS and they're doing all these things, and the elders are taking young men out to ceremony grounds and talking about AIDS as part of initiation ceremonies. So there's all of this community-owned and designed education happening about the virus. And the success of the campaign helped win an argument on NACAIDS, on the National Committee, that it was this rather than testing and quarantine that would work in Indigenous communities to stop the spread. And this, for the most part, was the approach taken, with some notable and important exceptions, which is in my book, but you might have to read it to find out about that because I don't want to talk for too long. But overall, this approach was highly successful. In the critical years prior to effective therapy, the incidence of HIV infection among Indigenous people in Australia did not rise significantly above that of the non-Indigenous population. This remains the case today. And in fact, HIV is one of the few communicable diseases that does not occur at a higher incidence in Aboriginal and Torres Strait Islander communities. It's a very sharp example, I think, of how the politics of self-determination can intersect with public health and transform the health of oppressed people. So I'm getting to the end here, but I'll leave you just with some final thoughts. So nurses were caregivers. They were also activists, both on and off the wards, and through their unions were instrumental in fighting HIV and the discrimination and homophobia that came with it. Nurses won a significant political battle over many years to stop the efforts of doctors and surgeons to introduce widespread traditional public health measures based on test and contain models. And they successfully advocated for and were part of developing community-led and controlled public health policy and programs. Far from the handmaidens of doctors, as they are so often cast, nurses were central to the social and political history of HIV and AIDS in Australia. And by centering nurses and their stories, it becomes clear that Australia's response to the virus was actually highly contingent and hotly contested. It wasn't just a gentleman's agreement between community activists, politicians and doctors. And with notable exceptions, and there are some notable exceptions, it was nurses and their unions, not doctors and their professional associations, that consistently pushed for the community-led progressive response that we now associate with the Australian public health model. So why does this matter in a broader sense? Well, I think the organising narrative of the Australian model and the story of a kind of gentleman's handshake, an unlikely partnership between medicine, the government and community activists carries a lot of weight. It has been passed down through queer generations of activists and community. It has played a role in shaping very particular orientations to the state and institutions like the medical profession. And these are orientations that put aside the suspicion and critique that perhaps has been a feature of earlier forms of queer political organising. By bringing nurses back into the narrative, it also brings back this question of contest, and with it the idea that some rights and some gains may actually have to be fought for and won. And I think today in the world that we live in, that's a historical lesson with a lot of value. But I'll leave it there.
I'm just going to ask, we'll have a conversation for a few minutes and then open it up to the room. That's all right. And please feel free to move if you can't see. Thank you very, very much for the wonderful talk. So I wanted to start off really going back to the book. Your project is built on oral history, on a practice of listening, and I'm interested in how you understand listening itself as perhaps a form of queer or feminist, as a queer or feminist practice of attention or care relating.
Well, that's a good question. Look, I guess it was important to me to have oral history as you know, it's really the backbone of the book are the oral history interviews. The archives are important, but the oral history interviews are the kind of heart and soul of it. Because, you know, most of the people I'd spoken to, that I spoke to had no sense that their story was worth telling or that anyone would want to listen to it. With some exceptions, like some of the more kind of community-attached gay men who'd gone on to work in AIDS organisations and those kinds of things, they very rightly had a sense of themselves as political agents whose stories should be recorded, and they were right about that. But particularly the heterosexual women I spoke to, was this kind of chunk of their lives that was unlike any other part of their life that kind of happened. They were, you know, in this whole new world, and then it was over. That's, you know, the other thing about HIV in Western context is over really quickly with the introduction of effective therapy, or at least the crisis years are over quickly. And then suddenly they're back to their normal world. So for me, it was really important, that practice of listening was really important to also, in some ways, give them a sense of their kind of political role and the significance of their story. So, yeah.
Did you see that practice as activist in some way?
Yeah, I think so. Like, I guess I'm activist. I saw it as activist in the broader sense, in that the book, I think, is a call for people to listen to those stories. In terms of the impact it had interpersonally on the people I was listening to, I guess I saw that more as a kind of, I don't know if I describe it as activist, more like I really wanted to do it. Like, it felt like I felt a moral compulsion or an ethical compulsion to do it. But the more kind of activist sentiment I had, I guess, was more around actually calling for these people to be listened to.
Would you say it was an act of care?
Oh. Yeah, I guess in some ways, yeah. I think, that the care question was also something I struggled with because, you know, that do people in the room do oral histories? Anyone? No.
I think they will. Some of them will be doing it.
Yeah, they're very hard. Oral history is really hard. Like, it's a very intimate relationship that you form very quickly with a stranger. Particularly for a subject like this, you're asking them to talk about, you know, maybe the best part of their life, but also a part of their life that was full of, like, terrible grief and some really horrendous stories. And I was, like, the same age as probably a lot of you. I was 25 when I did those interviews, and I didn't really know what to do with that. I found that really hard. So I think I probably had a sense of care in a broad sense to the people I was speaking to. How well I cared for them in those moments, I'm not sure. I was probably, in hindsight, a bit young to do that project, but, you know.
Well, what advice would you give to these students who are going to be going out and you know, dealing with difficult topics?
Yeah. I would care for myself a lot better next time I do something like this. Like, I would set up some, like, if you see a therapist or if you have access to a therapist through your university, like, it, you know, maybe doesn't sound like it would be that helpful, but I think it would have been helpful to have someone to download to after those interviews, because I started to have, like, quite weird reactions. Like, a few times I walked out of interviews and I was really, like, had this intense rage, and it was often directed at the person who I'd interviewed. Like, it was because I was sick. I was like, I can't hear another story like this. Like, stop telling me these things. Even I was asking people to tell me those those things. Like, it was totally, irrational. But I was very overwhelmed. Sometimes when you're overwhelmed, you have weird responses. But in hindsight, I needed to have someone else to talk to about that. That wasn't my partner, who also didn't want to hear it. So
I guess the stories that you heard were often, the lives these were people were living every single day. How did they cope with it?
Yeah, I mean, and I think that's why I didn't do enough to look after myself, because I was like, they did that, they actually did it. You're just listening to it. Like, what have you got to whinge about? I mean, I think in the book I talked a little bit about the different strategies people had. Some people, Siobhan, one of the nurses I spoke to, she had a ritual of like leaving it at the door. So she would say, when I walk out the door, I don't think about this again. And she just left it there. That's a pretty psychically challenging thing to do, I think.
Yeah.
For the gay nurses in particular, there was a real kind of distinction, I think. For some gay nurses, it was extraordinary. They loved it. They had this profound sense of contributing to their community, of being part of their community. Others just absolutely hated it, and they couldn't really cope with the coming together of their personal and professional lives and this sense of not having an escape. So those people, they struggled with drugs and alcohol. That was how they coped with it. It was the only way they could cope with it, but that had implications for their health. Some people coped by withdrawing completely from the gay community. So they were like, I'm a nurse now, I'm not a gay man, because I can't go to a club and see a patient. So it was, very, very difficult for them in particular.
So you discussed the fact that these histories have been ignored, overwritten, however you want to put it. But I'm curious, with new queer cultural institutions opening in Sydney, for example, how have these histories been recognised there, and if so, how?
A little bit. So, Utopia is the...
Yes. It was a very leading question. We went there together when I was recently in Sydney.
Which is a very weird museum.
Yes, this is what I'm coming to,
yeah.
yes.
They have an exhibition which is like a kind of hospital gurney from Ward 17 South, which was the AIDS ward in Sydney. What's really interesting about that exhibition is there's not much sense of the people. It's just a bed. And it's actually highly medicalised in that sense. You don't have, like that image I showed you of the drag queen on the ward. There's none of that. There's none of the joy, pleasure, sex that happened on those wards, because plenty of it did. Mm-hmm. Like, people were living their lives in very challenging circumstances, but they were living their lives. And I think, one of the things that I hope that the book does and that nursing stories can do is bring a little bit more of that flesh and blood to the story. That's not just a hospital gurney.
Okay. And just as a final question before we turn to the audience, so as you said, so you centre the role of nurses' unions in Victoria and New South Wales in particular, and them as shaping health responses, advocating for patients, and providing vital education to combat misinformation, homophobia. So Marilyn Beaumont, who you mentioned and who wrote the foreword for your book, said that this was partly, as you said, a feminist and queer mission that was, as you write, embedded in the socialist action of unions. So with this history in mind, what is or could be the place of nurses' unions today, both at a time when they're being attacked in Australia by central government and in a period, for example, of increasing discrimination and violence against trans folk, and particularly the curtailment of access to young people and sister girls and brother boys to trans healthcare?
Yeah, really good question. And I think there's such a lesson in this history for the struggle for trans healthcare now. I think the really important kind of takeaway there from this story is nurses, I mean, they were taking their own kind of agentful political positions on things, but they were informed by the agency and the demands of the gay community. And they used their industrial and their political power to back in those demands. And those demands were, fundamentally, there's connections between those demands and, the demands that, trans people and young trans people in particular are making now. It's about agency over body, over your own body, agency over treatment. It's a challenge to the authority of doctors to, tell people how their bodies should be, what their bodies can access. And this history of nurses actually backing that demand, I think, is really important now. And, something that hopefully can contribute to that discussion. I mean, wouldn't we be in a better place if we had nurses taking or threatening to take industrial action to support access to puberty blockers in the way that they, did around compulsory testing?
And do you think that's likely to happen? Is there any hope of that in Australia at the moment, the current context?
I wouldn't want to say no. It's not something I can see on the horizon, unfortunately. Like, I think, this was a time, like, nursing unions now in Australia are still very strong. They absolutely are strong. They are not the kind of politically radical unions that they were in the 80s. I mean, very few unions around the world. It's kind of a reflection of the time that we live in. Australia also has a tradition of, well, as does the UK, but of social movement unionism, of unions taking up demands around social questions, and particularly, in the 70s, most famously around questions of gay rights. So at Macquarie, my university where you visited, this is a very famous example of the pink bands, where the Builders Union actually refused to work at Macquarie because a college had expelled a gay student, which is kind of, it's an extraordinary story. It's a communist-led union. That's kind of part of the background. But there was this kind of big tradition in the 70s of the marrying of social questions and industrial questions. Unions struck for Aboriginal land rights. Like, this was kind of common parlance at the time, and the leadership of the nursing unions grew up in that. They really grew up in that. They grew up on the campuses. They grew up in that environment. It's just not the case anymore. We have a long way to go, I think, to build that kind of industrial and political consciousness. But I never want to say that it's.
Thank you. So, any questions? Yes.
Hi, thank you for the talk. It was amazing. And just to preface this question, it's ridiculously broad. So, sorry. Obviously, when we talk about HIV, we're very used to talking about it. Well, it was an epidemic, so we talk about it in terms of national boundaries. I'm quite interested in hearing about how the Australian response was inflected or did inflect international cultures. So obviously, you talk about how Auntie Graceland went in 1985 to America, which coincides with that International AIDS conference, which was held in the US. I presume she wasn't at that, but how was those sort of international conversations sort of coming in and informing the Australian response?
So Australia, because it's an island and kind of in the it's fairly isolated. It did have the kind of advantage of things happening a little slower. So New York was already in a very bad way by 83. But 83 was our first death.
Similar to the UK then?
Yeah. So I think, there was a sense of watching particularly what happened in the US and not wanting to do that. So, it inflected it in that sense. I think the Labor government as well, wanting to distinguish itself from Reagan and Thatcher, was a kind of factor, and sort of seeing, we don't want to be like them, basically. So that inflected the response. I think though, or I know that as well, there were kind of more positive things that were moved between national boundaries. So, for example, San Francisco and Sydney are kind of twin cities for the gay community. Like, lots of people travel between the two. So Australia is, really far away from things, but San Francisco is only one flight. It might be 10 hours, but it's only one flight. So, people do that. The AIDS ward in San Francisco, which was Ward 5B, they sent a bunch of people over to St Vincent's and upskilled nurses in AIDS care because they had been doing it for longer, basically, and had kind of tips, and they actually changed some of the kind of regulations around what nurses could do, like around prescriptions and things like that, based on some lessons learned at 5B around how that could be really helpful in AIDS wards. So there was, a very positive kind of transmission of knowledge between places. And AIDS nurses as well, once they had, Shan, for example, is a really good example. Shan then, after she worked in Australia, she was a community nurse in the eastern suburbs for a few years, and then she kind of left, and I think left quite abruptly. I think she became quite overwhelmed with the work that she'd been doing, moved back to London, and then started working in the AIDS ward in London, and kind of brought some of what she'd learned in Sydney. And then she went overseas and started working in South Africa, doing AIDS health promotion. So she kind of took these lessons from Sydney and moved all around the world with them, and also learnt new things, obviously, in those different geographies. So yeah, lots of movement of knowledge.
Thank you so much. That was such an interesting talk. I know that for First Nations young people now, like even though HIV rates are similar, all the other STIs. Oh, sorry. Of course. I was just saying that all other STIs have higher incidence rates amongst First Nations youth than non-Indigenous Australians. Do you think there are any lessons from this that we could apply that we're not applying in Australia at the moment?
It's a really good question. It's absolutely right, and in fact, all communicable diseases, I think, have higher incidences. I think I'm right in saying that. In First Nations communities in Australia. I guess I kind of touched on it. The lesson I think that comes through so clearly is about it's about self-determination and community power over kind of this very deficit model of public health, which is often the model that is taken to Indigenous communities in Australia and around the world, and in fact oppressed communities in general, and is not, people don't respond to it well. Why would you? Fanon actually writes about it in Wretched of the Earth. He writes about how the medical establishment are part of the colonial apparatus, and for colonised people, the experience of going to the doctor is the same experience as going to the colonial administrator. And it's absolutely detrimental. So the story of Condom Man, I think, is so important because it's the opposite of that. It's like these communities have the solutions. They can do it. Of course, it just needs to be some kind of resources, because all of the resources that used to be there have been taken away by colonisation. So something has to be given back so that people can actually, put into place the solutions to their own problems. And I think that's something that applies to all kinds of disease, communicable and otherwise.
Coming off of the Condom Man conversation, I wanted to ask about the visual culture of the kind of everything that was put out in terms of the video you showed us as well. What kind of genre were they all sitting in? I wonder if you could just expand on that slightly. It's not necessarily like a closed question. I'm just wondering if you could expand on the kind of images that was like where they were more bodily, how they compared to the images in the UK and US, for example, like the adverts that were put out, that a lot of them are kind of disembodied. I think in the UK, I was just kind of having another look at the archives and stuff, and a lot of them are just like big words and scary things. Just I was wondering how did that differ?
Yeah, it's an interesting question. I mean, I think like the Grim Reaper ad is very much in that tradition, and it had like a profound impact on people, on straight people particularly, which I guess is what it was designed to do. It was an ad for straight people. But even like just anecdotally, pretty much any time in Australia, if people ask what do you do, AIDS, and they're like, oh, the Grim Reaper. Like it's like such a thing for them. The bizarre thing about this ad is it played for 12 days. Like it had such a short run partly because it was so shocking. It had a really, really short run. But and they pulled it off because sexual health clinics became unmanageably flooded with people who absolutely didn't need to be tested. My mum describes, she went overseas, she went to like Indonesia for a couple of weeks and came back, and while she'd been in Indonesia, the ad had run, and she came back and people were hysterical. Like absolutely hysterical. Everyone was like, have you got your test yet? Like it was this huge kind of cultural moment. And obviously, you know, people have quite rightly written about how it, you know, in this in its kind of framing, the gay man is the Grim Reaper in lots of ways, like this spreader of death. And it's, you know, very, very problematic in that sense, and the kind of panic and the fear that it engendered. It is the kind of outlier in the imagery from Australia's crisis. And I think, you know, Condom Man it's not up anymore, but Condom Man is an example of a very positive, affirming image of safe sex. And the same as, maybe bring them up even, the other ones that I showed you, these, which are incredible, like they actually portray people having sex, bodies. This one is the artist David McDermott, which some of you might know. He did a whole series of these for Acon, these posters, and some people have them now in their houses. I'm very jealous. They're worth a lot of money now, obviously, because they're beautiful. And, you know, they're very embodied.
Where are these coming from? So who is Acon?
So Acon is the AIDS Council of New South Wales, and the AIDS councils were community-run organisations set up as a response to HIV. They were run by, you know, at the time, or in the early days, mostly gay men, but, you know, as the epidemic progressed, you know, some sex workers were involved as well, and IV drug users. And they were funded, you know, they were entirely funded by the federal government and by state governments. So even though this doesn't have a government logo on it on purpose, it was, you know, essentially funded by the government.
So that in terms of the UK response, it's much more from within the community that these images are seen. Right, so they come from ACT UP, from Lighthouse, those groups, and Black men's health groups in you know, major cities, for example. But what struck me when looking at that, the Grim Reaper video, was the fact that the narrator had an English accent, not an Australian one. Sort of spoke to the fact that this was almost an imported.
That's interesting. It's actually not an English accent.
Is it? It sounds very. If
I know
it's an English here. It sounds like
It's an Australian TV accent. Yeah. Sorry. Until kind of like the last 10 or 20 years, Australian TV, like news and things like that, had basically an English accent. Yeah. So, yeah.
Thank you very much. An astonishing story, which, as you so obviously say, needs to be told. Two things. I have an anecdote and then a kind of observation. My partner of 10 years died of AIDS-related illnesses in 1992. And we were exposed constantly to the extraordinary qualities of both the nursing staff at Broderick Ward and in the Middlesex Hospital, but also to community palliative team. And the thing that struck me was that all of them, I think without exception, were able to draw on resources of energy and compassion and empathy and humour and lots of other things as well. But there was just an astonishing degree of kind of heroic humanity all round, which I just thought was astonishing. And in that sense, there were a number of, this is a link really to my question, which is about the radicalisation of people through this experience, and us too, that we were facing inevitable death. And the ward was full of people, all of whom would die. And so there was no time for irrelevancies and fripperies, and you talked about the things that matter, you demanded the things you wanted. The nurses and the staff were disposed to find what you wanted. How, was it quality or quantity you wanted in your life? What medication would help you end your life in the way that you wanted? What medication would your partner and you agree? All sorts of extraordinary things, which was utterly remarkable. And it also had a radicalising effect on us too, I think, because we were given our entire dignity. Nothing was done without our consultation and our agreement. And all the risks, and all the options. It was just an extraordinary experience altogether. And that kind of radicalisation of both the profession and the patient in given those opportunities just leads me on really to the question. It just seems to me that HIV had the most extraordinary political, social, psychological, and spiritual radical impact for everyone it touched, and for lots of people who weren't touched directly, but who actually understood to some extent what was going on. And to hear you say that it was this kind of isolated portion for many people, not for everybody. I'm sure it changed the life permanently of some nurses and so on. But it seems to me a great tragedy that maybe the huge goodness that was exposed through this crisis, that systems and hospitals and communities and so on have lost that capacity, because we were moving in a world which was so different from every day now, and we've lost. You said the word lost. I think I'm just very interested in that phenomenon and how we can both kind of reconcile ourselves to it.
Yeah, it's a really good question, and that absolutely your experience reflects so much of what nurses spoke to me about, obviously from their very different perspective. I think, perhaps I was a little flippant in saying that it was an isolated period of people's lives. For some of the nurses, it was. They kind of went back to their normal lives. But for others, even though, they were no longer, working in AIDS care, by the late 90s, they kind of took a lot of the lessons that they learned into their next nursing role. So an example is that one of the women I spoke to, and she was actually the wife of a cattle farmer in regional Queensland, which is like really isolated. Like really, we're talking like 10,000 acre property and a house in the middle. Like seriously, middle of nowhere kind of thing. And she had a couple of kids. She'd done her nursing training, worked for a bit, married a cattle farmer, had a couple of kids. They grew up and she was really bored. And her husband said, why don't you go back to nursing? So she started basically commuting she redid her training or refreshed her training and was immediately allocated to the AIDS ward in Brisbane. So from a cattle farm to an AIDS ward in a kind of major city, and started working there for about 5 or 6 years. And she talked about, the kind of profound effect that it had on how she understood gender and human intimacy. And she has this beautiful moment where she said in the interview I couldn't believe the way those men cared for each other. I'd never seen a wife or a husband care that much for one another. Like, she was just really moved by what she saw, and it also changed how she thought about the capacity for men to care, basically. And then, so it kind of changed her ideas about gender. And then she, the kind of crisis, dissipated, or however, you might want to say it. And she ended up she became really passionate about palliative care, because she'd seen that people could have a good death because of exactly what you're describing. So when she went back to the cattle farm, in the nearest kind of community to her, she'd set up a palliative care ward, and she set it up in the model of the AIDS ward, where she would encourage people to bring things in from home, and it had like soft furnishings and music and things that actually made a death good, or made a death better than it might otherwise have been. And so in that sense, it really did live on, even though her connection to kind of HIV and the gay community ended.
I'm really sorry. I'm afraid we're going to have to finish up here, but there will be time for you to ask questions. We're going to have we've got some refreshments. Please join us to have some and have a chat with Geraldine if you'd like. But I'd just like to say again a huge thank